Good morning, everyone. This is Tammy Harper, and I am a nurse practitioner in transplant hepatology at Keck Medical Center, USC. And it is my great pleasure to be with you today speaking about the two Ps in hepatology, as well as the course chair for this GI symposium. So I'd like to welcome all my nurses out there. Normally by now would have gone around the room and met everybody personally, but since we're not able to do that in this environment, please feel free to put your name and where you currently work and what you do every day inside the chat. There'll be a question and answer session at the end, but if there's something that's pressing, just interrupt me and unmute yourself and ask the question, okay? So good morning, let's get started. Like I said, I'm going to be talking about the two P's in hepatology, and that is primary sclerosing cholangitis and primary biliary cholangitis. The objectives of my time together today is to review the pathophysiology of both of these diseases, PSC and PBC, as well as to review how to diagnose and the symptomatology of both of these disease processes, as well as to understand the different treatments that are unique to both of these. Before we get started, I want to talk about liver anatomy, just so you sort of kind of have a baseline working knowledge. And I know that you guys already do, but just for teaching purposes, just a quick review. The liver has two lobes, the right and the left. It has 8 segments total. And I'm going to use my mouse to sort of kind of scroll, and you can see on the left side is segment 1, next to the IVC, as well as segment 4, then segment 2, and then segment 3. On the right side, we have segments 5, 6, 7, and 8. I'd also like to go over the anatomy of the bile ducts, and especially since these two diseases affect the biliary tree. Let's start with just a quick review. As you see here, this is the duodenum. As we travel up, we see the pancreatic duct. Here's the pancreas here. As we continue to travel up, we see it becomes the CBD, which is the common bile duct, as well as we branch off into the common hepatic duct and then over to the left hepatic duct. And if we come to this side, we see the right hepatic duct. Now, if we head out this way, there's the cystic duct and the gallbladder. And so keep in mind when we're talking about the biliary tree, extrahepatic and intrahepatic, when we talk about these two disease processes. Now, I'd like to just quickly review some basic physiology of what a liver biopsy anatomy looks like. You just follow along, if you will. So this is the bile duct. Imagine this is a cross section. So this is the bile duct. This is the portal vein that sits and wraps adjacent to that bile duct. Here's the hepatic artery. We looked at the anatomy before. The portal vein and the hepatic artery supply blood flow to the liver. This is the hepatocytes, okay? And if you can tell, this is what's considered a portal triad. Okay, so if you hear those terms, that's what that means. And I kind of want to talk about what happens to the bile ducts when they're diseased or destroyed in either one of these processes. The small bile ducts merge into the common hepatic bile duct, and that common hepatic bile duct merges into the cystic duct and then into the common bile duct that we just looked at that screen, so I think you guys should remember it. I'll go back real quick, okay, just so you can see. So when we're talking about liver biopsies and destruction of bile ducts, this is what we're looking at. We're going to look at some slides later on in my presentation, just so you can have a basic idea of what on biopsy slide these two entities look like. Let's start with PSC. Primary sclerosing cholangitis is a chronic cholestatic liver disease characterized by inflammation and fibrosis of both the intrahepatic and extrahepatic bile ducts. This leads to the formation of multifocal bile duct strictures, okay? You also have the loss of lobular bile ducts. And now this is what I want us to start to remember. The age presentation are different in both of these disease processes. Usually in PSC, the age is earlier. between around age 30 to 40, and this disease happens more frequently in the male population, okay? It's also a progressive disorder that generally develops into cirrhosis, portal hypertension, hepatic decompensation, and a majority of the patients requiring liver transplantation. There are also variants of PSC. One is called small duct PSC, and that basically means that it has the same characteristics of PSC, except for on cholangiography, the bowel ducts look normal. So the lab pattern is the same and the histological features are the same if we were to do a biopsy. The second subset is called secondary sclerosing cholangitis, and that is just basically what it seems. It causes the same biliary stricturing. However, sorry about that, Megan. Now you can pick me back up. I'll start at the top of the slide. There are two subsets to primary sclerosing cholangitis. Small duct PSC, which is a variant of PSC characterized by the typical cholestatic and histological features of PSC, but there are normal bile ducts appearing on the cholangiography, okay? And we'll talk about what those classic findings are. There's also a subset that is called secondary sclerosing cholangitis, and that's characterized and creates the same beading and stricturing process, but the causes can be infection, long-term biliary obstruction, and inflammation that causes destruction of the bile ducts, okay? And sometimes it's difficult to distinguish between the two, especially if patients have had bile duct surgery or have had intraductal stone disease or even cholangiocarcinoma. Signs and symptoms of PSC: right upper quadrant discomfort, fatigue, pruritus, weight loss, and cholangitis, which fever and chills. Please know that that is not a common presentation for diagnosis. Usually a patient will come in and have some abnormal liver tests, usually the alkaline phosphatase, and that will require workup, including imaging, and that is how PSC is diagnosed. But I want you to know that cholangitis is a very prominent feature of this disease, and many of our patients have multiple hospital admissions for cholangitis, so much so that UNOS has exception points that a patient can receive for multiple episodes of cholangitis requiring IV antibiotics and ICU stays. The usual culprits in creating cholangitis in these patients are E. coli, Klebsiella, Enterococcus, Enterobacter, Pseudomonas, and so just be aware of that. On physical exam, splenomegaly, hepatomegaly, and jaundice are the findings that you'll have. Now, here we talk about the lab test abnormalities. I already said elevated alkaline phos, serum elevations in the aminotransferases, that's AST and ALT, up to 2 to 3 times at the upper limit of normal. Patients can also have elevated IgGs, and that's about in 60% of the patients. And for some of the patients, the bili is normal at the time of diagnosis. Now, there are some autoantibodies that can be detected in PSC, and the one that you would see is the p-ANCA. That's the perinuclear anti-neutrophilic cytoplasmic antibodies. Mouthful. So you can also see that elevated, and probably 85% of the patients, but it's not just specific, obviously, to PSC. Diagnostic testing. Now, this is where the money is. This is how we diagnose this disease. Most of the times we have ERCP, and all of my GI nurses out there know all about ERCP. The other is percutaneous transhepatic cholangiography and MRCP, which in this day and age is usually what we use. Is less invasive, but on an MRCP, you will see very what's the word I want to use? Classic findings, I think is what I want to say, that demonstrate multifocal short annular strictures alternating with a normal or slightly dilated segments, and it produces a beading pattern. It looks like a pearl, a chain of pearls. So a bead, a string, a bead, a string. And also on liver biopsy, which we'll take a look at that, there's fibrosis periductal that's concentric in nature, and it looks like an onion skin, very classic of PSC. This is how we diagnose it. Cholestasis pattern labs, we talked about that. Cholangiography, MRCP, we talked about that. That will demonstrate biliary strictures and beadings. And liver biopsy, we rarely need that, and it may not be diagnostic. So let's take a look at some imaging. Here's an MRCP, and just sort of kind of follow along if you can. Hopefully you can see this well. But this is that classic pattern of stricturing and beading that you'll see on imaging. And this as well, along here as well. And you can see here, not so much in C, but you can see the narrowing and a little bit of beading right there, okay? So that's what the imaging looks like. Now this is, once again, oh my goodness, this one I think is excellent, right? Because you can really see the beading and the stricturing as we move along the biliary tree. And just of note, and we'll talk about this a little bit further on, but if you have dominant strictures, and in the CBD, that's 1.5 millimeters or greater, or in the hepatic duct, that is 1 millimeter or greater, those require a closer look with ERCP, possibly with dilatation to try to relieve the bowel and reestablish the bowel flow out from that liver, and also stenting. Once again, GI nurses are probably more familiar with this than even I am. Here's retrograde cholangiography, where you can take a look as well and see this beading and stricturing that we talked about. And so I hopefully, if you have questions about that, but I think that everybody's probably seen that, that's been in a GI lab. Let's talk about the liver biopsy. So remember before, guys, I told you that this causes a pattern of fibrosis periductal, and it gives you this onion skin appearance. So here's my bile duct here in the center, and then circling around here is that onion skin appearance that I talked about, okay? And so that's not every patient that you have a liver biopsy in with PSC does not have this. The diagnosis is usually from radiography, an MRCP, but I do want you to know that if we had a liver biopsy, this is the finding that would be indicative of PSC. Just think an onion skin, and I think you can see that there. Here is my bile duct, and if you can see, look at all of this fibrosis and inflammation that's just outlining that bile duct, which means that there's a stricture. If we were looking at it in an MRCP, when the bile duct looks like this, that means that there's stricturing that's happened in that region. Treatment. Just so you know, there is no medication, there is no treatment for PSC. We talked about treating the dominant strictures. Here are the diameters that we talked about again, and those should be treated with ERCP, dilatation, or biliary stenting. On the AASLD guidelines, they talk about surgical intervention. I've been doing this for 9 years, and I've never seen anyone have a surgical intervention for prominent bile ducts. I've not seen that. We use the ERCP most frequently. Now, these are just some things to remember. These things go along with PSC, inflammatory bowel disease. About 70% of patients who have PSC also have inflammatory bowel disease, usually ulcerative colitis. As you know, that patients with ulcerative colitis have an increased risk for colorectal cancer. And so our patients that have PSC and IBD need annual colonoscopies. There's not a lot of correlation between the severity of the IBD and the PSC. And if you treat the IBD, it doesn't really have any impact on the PSC and the course of the PSC. As you know, and then once again, I think I already just talked about this, that IBD is can occur in about 70% of our patients with PSC. And usually the IBD is caught first and then the PSC is diagnosed. Now, this is something we absolutely must be aware of and on monitoring with our patients with PSC. They have an increased risk of cholangiocarcinoma, about 15 to 20% increased risk of developing cholangiocarcinoma because of those dominant strictures that we talked about, and the fact that the bile cannot flow out of the liver. And so CA 19-9 are the tumor markers that we use, but I think you guys are probably aware that there are other disease processes that cause elevations in the CA 19-9. And so while this is something that we monitor, this is not definitely diagnostic. Pancreatic cancer can also cause an increase in the CA 19-9. Cholangitis itself can cause an elevation in the CA 19-9, as well as non-malignant pancreatic or pancreobiliary disorders, and so, or obstruction. So just keep that in mind. We usually obtain for our cirrhotic patients CA 19-9s twice a year, so every 6 months. Okay, this is just the natural history and progression of the disease from the time of diagnosis until death or liver transplantation is usually about 8 years. Okay, it can be the factors that make this vary is the stage that you're diagnosed, the differences in the rates of progression for each individual, and the heterogeneity of the disease itself. This is our PSC risk score that we use to determine a patient's probability of survival. And these are the 4 things that are factored into that. Actually, it's 5: the age, the bilirubin, the albumin, the AST, and if the patient has had a history of esophageal varicose hemorrhage. Obviously, if I plugged in a bilirubin of 4.5, that would make this risk score go up and decrease the probability of my patient's overall survival. And so these are the things that we use to determine the patient's survival, if we are listing them for transplant and things of that nature, as well as the MEL score. Okay, so that was my rapid fire PSC, but just keep these in mind. Patients with PSC have an increased risk of cholangiocarcinoma. Patients with PSC are usually male and diagnosed earlier. The diagnosis for PSC is made usually from imaging. Our MRCP is the gold standard. We want to watch out for dominant strictures, as that should put us on high alert for cholangiocarcinoma. Also, our patients with PSC are at greater risk for IBD, especially ulcerative colitis, which also puts them at risk for colorectal cancer. And so those are the takeaway points that I want you to keep in your mind when you think about patients with PSC, okay? Now let's shift gears a little bit and let us move to primary biliary cholangitis. Okay, this is an autoimmune disorder because its hallmark features are that positive AMA, okay, anti-mitochondrial antibodies. And it also has some specific bile duct pathologies. The etiology is thought to be a combination of either genetics or environmental triggers. And now here comes the difference. Most of the people who are diagnosed with PBC are average age of 35 to 60. That's the range. The average age is about 50, and it's women. 90% are women. Okay, remember our PSC, it's men and much earlier. PBC, and that is primary biliary cholangitis, previously known as primary biliary cirrhosis. We changed the name of this disease probably about 3.5 years ago, 4 years ago, because all of the patients don't progress to cirrhosis any longer, especially with early diagnosis and the administration of ursodiol, which we'll talk about a little bit later on. Now, annual occurrence, this is a wide range of numbers from 2 to 32 million worldwide. All races and ethnicities can have this disease, but usually found in Caucasians from the UK, people from Scandinavia, and in the US, lots of people in Minnesota have this disorder. It's rarely diagnosed in patients who are from Asia or African descent. Here we go. It under microscopic evaluation is intrahepatic bile duct injury, portal inflammation, necrosis of the intralobular and septal bile ducts, and its progressive destruction with inflammation that leads to bile duct loss, fibrosis, and eventually cirrhosis if not treated. Okay. Early stages, patient could be asymptomatic and may once again have an incidentally elevated alk phos. One of the hallmark features of PBC, though, patients complain of severe fatigue, and we'll talk about that. And the later stages, patients complain of pruritus, jaundice, ascites, and become cirrhotic and can even have esophageal varices and portal hypertension. The fatigue is the most common symptom. 50 to 70% of patients have that. Then secondary would be the pruritus. The itching is debilitating for some of these patients. Vague right abdominal quadrant pain. Because PBC is an autoimmune disorder, there's also some associated overlap diseases as well, including Sjogren's, Raynaud's, sclerodactyly, and telangiectasias. All can be found in patients who have PBC. I mentioned this, progressive liver disease leading to portal hypertension and cirrhosis. So I talked about this Sjogren's. 70% of the patients have Sjogren's syndrome. Gallstones, arthritis, scleroderma, 15% have that. Crest syndrome, celiac disease. And so know that these can be associated features of PBC. And if you see a patient in PBC, we also want to ask the questions of, have you had dry mouth? Have you had dry eyes? Those things. On physical exam, hepatomegaly, you also find excoriation of the skin because of the pruritus is so severe. You get jaundice, edema, spiderangioma. And I said, once again, if they have developed portal hypertension, then we have edema, ascites, esophageal varices, splenomegaly. Okay. Diagnosis, cholestasis lab picture, and the AMA is the hallmark of diagnosis. This is found in about, let's see, 95% of the patients. Also, they can have elevated IgM levels. And if you happen to have a liver biopsy, you don't necessarily need it for the diagnosis, but if you do, what you're going to find is evidence of non-superlative cholangitis and destruction of small or medium-sized bile ducts. And we're going to look at some biopsies now on PBC patients. Here's one. You also find this large portal. It's called a portal granuloma. Here's my bile duct. You can see this lymphocytic inflammation all around my poor little bile duct. And if you see this with an AMA, you pretty much have elevated AMA, you pretty much have your diagnosis of PBC. Once again, here's my bile duct. You can see the lymphocytes attacking the bile duct and trying to infiltrate that bile duct. Okay, you can also possibly may see plasma cells as well. Now, this is just sort of kind of a histologic progression of the disease. Here's the ductal atypia that we talked about, that portal granuloma. Here's my little bile duct here. Here's the infiltration that we see with the lymphocytes into attacking my little bile duct. I call it my little bile duct. And then let's move over to the right of the screen. This is a trichome stain, and everything that you see in this bluish color here is all fibrosis and scarring of the liver. Okay, and so this we're now advancing to cirrhosis. Okay, now silent preclinical phase, the AMA is positive. This could last for decades. It depends. The patient could be moving into the asymptomatic phase, and then gradually there's an elevation in the alkaline phosphatase. And once you see that, patients usually within 5 years of that become symptomatic. The median, the symptomatic phase can last for 6 to 10 years, and that's also their median survival at that time. The key to this is early diagnosis, guys, and getting the patients treated with ursodiol, and we'll talk about that. Okay, and then we have the pre-terminal phase, progressive jaundice, and that can last up to 2 years. Okay, once again, there's a calculator. It's called the PBC risk score. And this one, how old is the patient, what the patient's bilirubin is, what the patient's albumin is, lower albumin, poor predictor of survival. Does the patient have edema, and is the patient on diuretic therapy? And I think we talked about this, what's the patient's prothrombin time? And once again, this is calculated, and it gives me the patient's survival at 1 year, 2 year, 3 years, and 4 years, okay? Complications of PBC, we talked about this. There is dry eye, dry mouth, there's osteoporosis, hyperlipidemia, severe pruritus that's just debilitating, and also deficiencies in the fat-soluble vitamins A, D, E, and K. Hallmark symptom people complain of is fatigue, as well as pruritus. And the treatments for pruritus, cholestyramine, which are bile acid sequestrant, naltrexone, Narcan, which is an opiate antagonist, sertraline, which I've tried that, limited success, rifampin, which is my last resort, and I've had a fair amount of success with that. I'm always nervous to pull that out because you guys know that rifampin can also cause, is one of those drugs that can give you drug-induced liver injury as well. These patients need bone protection. They need calcium replaced, vitamin D, and it can also require actually a biphosphonate as well if they actually have osteoporosis. And once again, we talked about this, those fat-soluble vitamins that need to be replaced, vitamin A or vitamin K should also be monitored. Now, the good news is ursodiol. It's the first line of therapy. It was approved, I think, in 1998 by the FDA, and it is still the mainstay treatment for patients with PBC, okay? And I want you just to take note of this study. Look at this transplant survival at 5, 10, and 15 years of 90, 78, and 66%. With URSO on board versus the 79, 59, and 32%. That's pretty impressive. Starting dose is 13 to 15 milligrams per kilogram per day. And we don't exactly know how it works. It's thought that it's cytoprotective, that it's got some anti-inflammatory and immune modulatory properties. But what we do know is that it helps the liver drain and evacuate the bile better, more efficiently, and so that you don't have that bile stasis and the bile ducts being damaged and destroyed. This is a picture of what a hepatocyte looks like, and the bile acids, and this is basically letting us know that with URSO on board, we have a reduction of the bile toxicity, which is what we need to treat these patients. It keeps them from developing and progressing to, remember that trichome stain I showed you that had the fibrosis on it, and so that is our goal. Also, there's more help on the rise, and there are patients who just don't, for whatever reason, respond to URSO, and now we have obeticholic acid to add, and there's one study that shows that this can improve transplant survival from 60 to 72% with the addition of obeticholic acid. And so just what this drug is, it is an FXR antagonist, which basically decreases bile acid synthesis and decreases the uptake and increases the secretion of bile acids in and out of the liver. Okay. It also has mediates anti-inflammatory and anti-fibrotic pathways, all in our effort to help our patients salvage those livers that have PBC and not require transplantation. It's my time. Okay, I'm almost done. And this is really for patients who are poor responders to ursodiol, but there are also some studies that are showing these in combination, and I think that will be the future mainstay of people who have PBC once we have more data. Now, for both disease processes, once the patient becomes cirrhotic with manifestations of portal hypertension, please consider referring them for liver transplantation. And PBC, we sort of kind of use, once the MEL score exceeds 14, but once the person has, you don't even have to worry about that. Once the person has manifestations of portal hypertension, they deserve, I think, a referral to a transplant center for evaluation. Obviously, I'm here at Keck, and so you can feel free to refer them to me. We also do living donor here as well, and would be happy to see your patients. Now, I have a quick story, and I hope they don't cut me off. Years ago, when I was a new nurse, I thought I got floated. I was at UCLA, and I got floated to the liver transplant unit, ICU, because I did neurosurgery. I liked the brain back then. And after I was there for a week, I think one of their nurses was out sick, and I just remember thinking, who in the world would do this every day for a living? I mean, there's so many blood products that need to be given between the platelets and the FFP and the blood transfusions. All of the patients were jaundiced. They all looked so deathly ill. And I thought that only a lunatic who needed a posy vest would do this every day for a living. I have become the lunatic in the posy vest, and am quite happy to be that person. So thank you for your time and your attention. I am here and open for questions. Thank you.